next up we have Genevieve Maiden, who works with the War Memorial Hospital, and Genevieve's talking to us today about integrating care from the ground up, delivering anticipatory, interdisciplinary integrated care for older people with complex needs.
Threw lots of big words in there for you. Well done. Okay, so thanks for joining me this afternoon. So just to give some context, War Memorial is an aged care rehabilitation facility owned and operated by Uniting, but part of South East Sydney Local Health District. So we work with people over the age of 60 predominantly, or people with geriatric syndromes, so those with young onset dementia, young onset Parkinson's and so on. So I guess the aim of today's discussion really is just to talk about our journey in terms of, providing an integrated approach as being core business for what we do at War Memorial. So like we've heard of many services, if you look, sort of 9 or 10 years ago, our services really were quite siloed. We were providing single discipline treatments, of which people were quite content to come in for their physiotherapy. But equally, we were hearing from our consumers that there was that disintegration of care, that when there was a particular illness or, might be frailty, Parkinson's, whatever it might be, that there was a lot more to their care than just that person that they were coming in to see for that particular impairment. So really what they were hoping us to work with us on was to provide that integrated support where there was good coordination, where there was individualised care planning, and there were treatment approaches to support all of the different experts together in a sort of a coordinated approach. In terms of talking to consumers as well, that disintegration really led to carer stress. So in providing what's already a very sort of difficult situation, we were adding to that by this inability of our services to provide care, a coordinated care approach. Equally, we weren't including carers as much as we could in their health journey. Importantly, people over the age of 60, as we've already been hearing, geriatric syndromes don't just come as one diagnosis. So someone might be referred to you for frailty or because they're pre-frail, but they're certainly going to have anything between a couple through to 10, 12 other issues, medical issues that may be occurring for them. So when we're providing care, there's no point in providing care just to address the issues of frailty. We need to provide care that's broader than that and meeting their whole of health needs. And equally, we're thinking about wellness type approaches. So we talk about us being a health system. We've heard before that really we're not, we're an illness system. And so we need to go beyond just providing services which impact on impairment and actually help people to live well and focus on quality of life and working towards their particular health goals. It was important for us to be really engaging with our stakeholders, and so throughout our journey we've done an awful lot of work in terms of meeting with the people that are experts. War Memorial is a small hospital and we can't do everything and we don't want to do everything. So important for us was making sure that we were engaging in partnerships where that there were particular groups that were actually able to provide care or supports and that they're the experts in this space. So examples for that are things like working with Dementia Australia, Health Justice Partnership, which I'll speak to a little bit, and really tapping into the resources that are already existing in our community and funded already to provide certain supports. A big focus for us in working with our acute partners, so we have two big acute facilities in our district, in the northern end of our district, so St Vincent's Hospital and Prince of Wales Hospital, and they said to us that there were a lot of people coming through their EDs where they really felt that those admissions were avoidable. There's obviously a big cost related to avoidable ED admissions, but equally it's a very poor outcome for an older person that has multiple issues. So we know that once a frail older person enters the acute facility, that if they are admitted, they have more complications, they have worse outcomes, they have a longer length of stay. So economically not great, but most importantly really not very good for that older person. So we know, and thanks Isabel, because you've already talked about what sort of a geriatric syndrome, what that sort of means in terms of a term. So these are a number of the different sort of syndromes that we'd see coming through our service. So, and we know that the prevalence of these issues is growing. So we've got an ageing population, and that these issues, along with just the growth in our population, are actually increasing in prevalence also. In particular, dementia, we know that it's the leading cause of disability in older people, and I don't think a lot of people are aware of this. We talk a lot about diabetes, around cardiovascular disease, but really dementia is sort of the burning platform, I think, in terms of the delivery of care for older people, and it really impacts on the way we're able to deliver care when people have cognitive impairments. We've got a society where health literacy isn't high necessarily anyway, and you add on top of that cognitive decline, we really need to rethink the way that we're delivering care, and particularly including carers in the health journey. Elder abuse is another one as well, which I think we're starting to see or perhaps more aware of. The prevalence isn't known, and so we're trying to work in this space to understand what is the real need and to be able to put a percentage of how many people are actually experiencing abuse in any given year. So what do we know works? Well, we know that interdisciplinary care is best practice. We know that people's health needs don't stop at 5 o'clock on a Friday, so that after-hours support is really important. We know that wellness models and reablement models, rehabilitation is best practice. So when we're thinking about the way we deliver care, it needs to be more than just fixing something. It needs to be about empowering people and giving them the knowledge, skills and tools to be able to manage their health in the longer term and to actually live well in the community. We know that health coaching is a key part of that. So my colleague Brendan from South East Sydney presented earlier on around health coaching, which has been a big part of improving self-management in our local health district. And we know that early intervention is not only cost effective, but it's also better for our clients. So particularly when you look at the evidence for Parkinson's disease, for dementia, for some of those other neurodegenerative conditions and frailty and pre-frailty, the earlier that people are referred and actually undertake some sort of rehabilitation program, the better the outcome for them in the longer term. So in thinking about all of that, so some of the challenges and also what we know is best practice, I suppose I'm just wanting to share with you some of the things and the enablers that have helped us to come to what we consider is a very integrated approach to care at War Memorial. Now this makes it look very neat in terms of a linear approach to getting to that change, but as you know, it is really messy and these things have been happening in parallel and different focus at different times. But I would say that there's been some sort of structural changes that have really helped in terms of providing integrated care, and that consumer participation has been a really big part of that. So we did set up an integrated care committee. So this provided a governance structure where we had people from the Primary Health Network, from the ACI, from our district partners, acute partners, community providers and GPs all around the one table. And I think that's really important because it gives us, that communication platform to be able to understand challenges in our, community and to be able to work together as part of that. We also, in any change, we're always undertaking sort of a gap analysis, focus groups, discussion with consumers around what they see as the needs and the challenges, and we work on those issues together. So having stakeholder forums, consumer forums, sometimes we bring all of those people together. Quite often with our consumer groups, we find that separating them away from that health speak is important, particularly in people with dementia where they're don't feel confident to speak up in an environment where you've got a lot of health professionals around the table. So we are thoughtful about the way that we're engaging with our consumers to make sure that we're really getting their story and making them feel assured that we're hearing them. Clinical redesign's been a big part of what we do. So we haven't been given we haven't been given any really extra resources in order to change the way we deliver care. So we just had to get smarter about the way we were doing things and use the resources we had, and to tap into the enthusiasm and the skills of our workforce. So we've had a look and we have used clinical redesign's principles and the building partnerships framework, which was rolled out through the ACI, to help look at the way we deliver care and create change. We use the PDSA approach, so we'll test things, we'll jig them a little bit more and then we'll keep going. So it's using those constant small tests and re-evaluating what we do. And we spoke, I heard earlier in the lecture around the importance of evaluation plan and setting that up from the very beginning, and I think that's very true. I think sometimes we can jump in very quickly and then we're not quite sure if we've made a change. So we're always very key in terms of setting up that evaluation plan from the very beginning. So as I mentioned before, staff, consumer and stakeholder engagement is really crucial across different areas, and translational research approach. So we have, where we can possibly do so, get grants to help us write up some of the data that we've found through our projects, and partnering with people that do this well. So the University of New South Wales, supported us with patient activation, working with CHIBA through the University of New South Wales again in terms of looking at dementia data. So these people do research all day. We're not the experts in this, so we've been tapping into that research resource to support us. And I'm encouraged to hear that RCAs aren't the be-all and end-all in integrated care, because we wanted to get good data, we wanted to write it up, but equally we didn't want to spend years in an RCA process. So that's kind of the approach that we've taken. And really crucially is executive and board support. So we are constantly working with the executive team to make sure that they are very overt in terms of their vision of integrated care. So they're constantly using the language, that they're constantly speaking to our staff about how we're evolving and as an organisation, and bringing the board in on that as well, making sure that people right throughout the organisation are really clear on where we're headed. So a couple of our programs, we have a health justice partnership which is set up on site, and that's partnering with Seniors Law in New South Wales. So some of you may have heard from Lottie Turner, who's at Health Justice Australia. She spoke. So this is working with one of those types of organisations. We received a grant through the Commonwealth Attorney General and partnered with Justice Connect to basically bring an on-site legal support to people with the aim of preventing elder abuse. We have a lawyer 3 days a week, every week on site, and I think that's what's been really key to this partnership. Is quite often with these legal services, they might pop in for a few hours and they're quite disconnected for the clinical team. And what's been really good about this partnership is the fact that the lawyer is very much part of the clinical team. So they go to case conferences, they provide a huge amount of education to our staff. So they're very much engaged in our clinical work. The Management of Dementia Squad is another one which we're just about to kick off. So this is an interdisciplinary program specifically tailored to people with dementia, and this has come as part of our strategic plan, because in a lot of our consumer stakeholder engagement they were saying that all these programs are out there but you're not really meeting our needs in terms of in the dementia space. So a bit more to come in terms of that one. Our Geriatric Flying Squad is another integrated program that we run. So this kicked off in 2010, and at that stage it was a multidisciplinary team providing rapid response service to people in the community that were at risk of reduced quality of life or potentially of hospital admission. So the GFS, I think what's quite unique around this service is that they've partnered with first responders, so with police, ambulance and fire and rescue, because what we were finding is that those first responders had a lot of trust in the community and that they were having touch points with people in the community that might not be necessarily accessing health services. So by doing a lot of education and working with first responders, they were able to identify a frail person in the community or someone that they felt that was at risk. Similarly, they've been educating us, for example, in what does a house look like that would be a big fire risk. So we may go in and see someone and think, wow, this place is a fire waiting to happen. So equally we can refer back to fire and rescue so that they can follow up with a home safety check from their end. So it's those kind of reciprocal pathways which I think are really a credit to the team, because they've worked hard and long to get those partnerships going. In 2017 we received some enhancement funding, so that meant that the GFS could go into residential aged care facilities with the aim of reducing avoidable hospital admissions for people. And certainly the feedback we get from the residential aged care facility staff is that they feel more confident in identifying a deteriorating patient, that they know who to call, and that the first port of call doesn't have to be an ambulance into ED. So one of our other programs we run is the IREAP program. So this is Integrated Rehabilitation and Enablement Program. So this is a fixed program which brings in all of the different allied health, geriatrician and continence nursing services in the hospital. So it was through a sort of a redesign of our outpatient and community services that we were able to bring this program together. A big part of it is health coaching. And we feel that that's been really key in terms of getting those long-term health changes for participants. So we have been able to write up an observational study looking at the data of this particular project, and we looked at a number of measures related to this. We've just took a year's clients, so we took 111 clients and had a look at the outcomes for them. So in terms of clinical frailty, we were able to see statistically significant change in their frailty, where people went from being mildly frail or vulnerable to managing well. So I think that for us showed that quite often the perception is that you can't do anything about frailty, and once you're frail and old, that's it. But this just sort of showed that that's not necessarily the case. We had a look at people's quality of life, and we could also see statistically significant improvements and change in that as well. And we did look specifically at people who had Parkinson's disease and their quality of life measure, and that also improved as well. A key measure that we looked at was patient activation. So this is a way of measuring people's knowledge, skills and confidence in managing their health. And it was a way of us measuring the health coaching component of the program. It also helped us to tailor our care. If someone was a level 1 engagement, it could mean that they're completely overwhelmed, and we need to be very careful about the goals that we're setting with that person, right through to someone that's level 4, where they're probably able to manage quite a lot in terms of goals, and it's more around sustaining their health change going forward. So we also did see a statistically significant improvement in terms of the PAM score, which is great. We have used health coaching, as we mentioned, quite a lot, and we're using sort of a group model as well as individual sessions with clients, and we found that really effective. And in following up clients at a year post-program, we saw that the number of falls they were having in a year reduced from 5 to 2, and that 56 out of those 99 clients were still enabled, meaning that they were still engaging with whatever community program, exercise program, whatever it was that we'd recommended in order for them to maintain their health in the longer term. So just to acknowledge all the different team members and people we've been liaising with, and there's some of the references if anyone's interested. Thank you.